We know that with the femtosecond laser, there is the opportunity with dark surgery to increase the outcome of keratoplasty in especially keratoconus patients. We know that dark surgery leads to a potential advantages concerning reduced risks of intraoperative risk like intraoperative bleeding or postoperative endophthalmitis. There is a lower risk of graft endothelial rejection and a potentially longer graft survival. Several randomized controlled trials have been shown that visual acuity might be the same or a little bit lower in dark cases. However, endothelial cell density and the failure or rejection rates are lower in the dark group. So when we look at the typical cases or patients that are receiving dark surgery, which are younger patients with keratoconus, and we look at the average survival of penetrating keratoplasty of about 50% after 20 years, the potentially reduced need for repeat keratoplasty probably outweighs the probable reduced visual acuity in dark cases. So when you want to start manual dark procedures, there is the drawback of a relatively flat learning curve, a long learning curve, which has the risk of unintentional penetration during manual side cut, the risk of unintentional penetration during the big bubble maneuver with a sharp needle or a cannula. And if you cannot achieve this big bubble, there is an unknown residual stromal bed thickness when you perform manual dark procedures. So the femtosecond laser might be a tool that really helps in these cases. We know that femtosecond laser can help you to get a better side cut geometry. It can help you to get better centration of the trephination. It will lead to less damage of endothelial cells in the donor, and you have a very high accuracy concerning the depth of the cut. Additionally, the Ziemer platform also provides an intraoperative OCT scan, and this helps to precisely measure the patient tissue or the donor tissue during the trephination, and it enables to adjust the planned incision intraoperatively. The group of Seiler and Schmidinger recently published the high precision of the OCT-guided incisions. And this helps to enable the device to cut very closely to the Siemens membrane, which the company used to introduce the DALK tunnel, which is a platform to insert your DALK cannula very closely to the Siemens membrane. So when we use this device, we can adjust the lamellar cut, the side cut, and we can use these devices to adjust, to keep the safety distances to the endothelium. And further, we also can adjust the DALK tunnel very closely to the endothelial cells, to the Siemens membrane. And the company will in the future provide a new software update, which should come in the next months, which will provide a color-coded and simplified projection, and also the possibility to perform mushroom DALK procedures, which will have additionally benefits for the outcome of DALK procedures. To evaluate these developments, we designed a multicenter trial where we retrospectively evaluated prospectively collected data of 2 surgical centers with manual DALK and femtosecond laser DALK cases between 2011 and 2017. Those centers were the Department of Ophthalmology in Vienna and the IROC Institute in Zurich. Patients were divided in 2 groups. In the manual DALK groups, we included 51 eyes, and in the Femto-DALK groups, 73 eyes. The study design included patients with an average age of about 40 years in the manual and in the Femto group. Male patients were more than female patients, and most of the patients, about 75%, had keratoconus, and the residual parts were mainly stromal scars or disc corner dystrophies. We investigated the rate of successful big bubble achievement, the rate of micro or perforation of the Siemens membrane, rate of conversion to penetrating keratoplasty, rebubbling rates, and surgical time. Clinical parameters were evaluated as visual acuity 3 months after suture removal and mean keratometry in the 2 groups. When we look at the successful type 1 bubble achievement, we had an increase in type 1 bubbles from 71% to 82% when using the femtosecond laser. This difference was not statistically significant. However, the rate of microperforations or perforations dropped significantly from 42% to 19%. Also, the rate of conversion to penetrating keratoplasty dropped from 33% to 12%, which was also statistically significant. The rate of rebubbling dropped from 15% to 5%, although this difference was not significant. And in our center in Vienna, we also evaluated surgical time because the introduction of a femtosecond laser might increase the burden in the surgery room, but that was not the case. Surgical time was comparable between manual DALK and Femto-DALK. Further, there were some differences between the two centers. Both had an increase in successful type 1 big bubble achievement and a drop in conversion rates. However, there have been differences in the rates in the two groups. We see that the conversion rate was higher in the manual DALK group in the center 1, as well as in the Femto-DALK group in the center 1, compared to 0% in center 2. We had 18% of conversions in center 1. On the other hand, we see that the rebubbling rate was inversely correlated to the conversion rate, means that the conversion rates and rebubbling rates are in some cases surgeon dependent, but in both cases we found an increase in successful DALK procedures when using the femto laser. Further, in the Vienna group, we found that in the manual DALK group, we had 4 cases of unintentional perforations during the manual trephination or needle insertion. And this was never observed in the Femto-DALK group in the Vienna study site. So no case of cut-related complications were observed in the Femto-DALK group. Visual acuity after suture removal, as well as mean keratometry, was not statistically significant between the two groups in any of the centers. So in conclusion, we found a significant lower rate of perforation or conversion to penetrating keratoplasty in the Femto-DALK group. We had no case of unintentional perforation during trephination or cannula insertion in the Femto-DALK group, and we had a high big bubble success rate in the Femto-DALK group. So the femtosecond laser increased the reproducibility of DALK surgery and likely helps to make DALK surgery more accessible to unexperienced surgeons. And as an outlook, the new Mushroom DALK software might further increase the success rate due to the smaller internal transplant diameter, which would help since dual layer anatomically is limited to the center of 7.5 to 8 millimeters. Thank you very much.
Thank you, Gerald. That was very interesting. So just a quick question I was going to ask, what's the, you showed there seemed to be a shorter learning curve with this procedure, and the most of the cases you've shown have been keratoconus. Do you think, what is your ideal case that, say, somebody is going to start off with? Would you ask them to start with a cone? Would you ask them to start with a post-infectious scar? Or would you ask them to start with a corneal dystrophy case? What will be the first case you'd ask a novice surgeon to start with?
I think that keratoconus might be a good case to start off. Corneal dystrophies might be difficult, especially some type of dystrophies are difficult to perform a DALK surgery. Stromal scarring, if they're superficially, it should be okay. But I would try not to do DALK surgery as first cases with deep scarring or in cases with keratoconus with deep scarring, because they have higher risk of unintentional perforation.
Okay, great. Okay, thank you, Joe. Thank you.